Good afternoon. This is Sarah with the Department of Medicaid. It's not quite 2 o'clock and we're still clearing out the waiting room, so we'll give it just a few minutes before we get started. Dr. Schuster, it's 2 o'clock and your waiting room is cleared. Oh, and TJ's joining us now, so ready whenever you are.
You're muted, Sheila.
Thank you, Steve. Aaron, did you see Mary Haas or Tara Hyde?
No, ma'am. I will keep an eye out for them.
Okay, great. But we have a quorum, so thank you very much. And good afternoon, everyone. This is where the PA system comes on the plane and says, this is the BH TAC, and if you're on the wrong plane, you still have time to depart, but we're glad to have you on. I'm Sheila Schuster, Executive Director of the Kentucky Mental Health Coalition and Chair, and we welcome you all. Let's see, let's have the voting members. Steve, I see you first. Would you introduce yourself, please?
Yeah, I am Steve Shannon, the Executive Director of CARP, Association 11 of 14 Mental Health Centers. Glad to be here.
Great, thank you very much. And I think Val, I saw you next.
I'm Valerie Mudd. I'm with NAMI Lexington and Participation Station. I'm here as the consumer voice, people living with mental illness like myself.
Thank you very much. And Misty?
Hello, I'm Misty Agney. I'm a manager at Frazier Rehab, representing the brain injury and stroke patient populations, and a provider.
Great, thank you very much. And TJ?
Hello, TJ Littlefick, NAMI, Kentucky.
Great, glad to have you. And I didn't hear from Mary or Tara, so they may be on, but we do have a quorum. So the minutes of our July 11th meeting were sent out in advance. And I would entertain a motion from one of the voting members of the TAC for their approval.
So move, Steve Shannon.
And do we have a second, please?
I'll second.
Val, all right. Any additions, corrections, omissions?
My apologies. Can we have all voting members on camera, please?
That's right. That's the open records. Yeah.
It keeps wanting to put me in driving.
And we saw you briefly. There you are, TJ.
I go,
Okay.
Yes.
All those in favor of approving the minutes signify by saying aye,
Aye.
aye.
and opposed like sign, and abstaining. Thank you very much. We sent in a recommendation to the MAC at their May meeting. And when we met in July, we had not yet received the reply. I think it actually came the day after our July meeting. And I circulated that to the voting members and to others who typically attend these meetings. And I'm wondering if you all feel like our question was answered. We had made the recommendation that Medicaid provide written guidance to providers about the pre and post payment audit procedures and how each MCO is implementing the process. And what we got back was the information based on the language in the MCO contract about what the MCOs are supposed to do. And the fact that providers will be given 45 days to submit the documents. So I'd like to open it up for a minute. And Tara, welcome. I see that you're on. Thank you.
Dr. Schuster.
Yeah.
Oh, Mary has also joined us for the
Okay,
record.
great. Thank you very much. So I would like to open it up for a minute or so, not only to the voting members of the TAC, but to others in attendance who are providers, to see whether it gave you enough information to know what to expect in the case of a pre or post payment audit, and if there's additional information that you would like to get from DMS.
Sheila, could I get a copy of that?
Yes, I sent it out to everybody that's on my list. Do you have a copy of it there, Erin?
I don't, but if you give me just a few minutes, I can try to get it pulled up.
Okay, it was sent on July 12th.
Okay, I'm a provider and I don't remember seeing that, and that would be very helpful to me.
Yeah, I don't think, just to clarify, I don't think that DMS sent it out to providers. They sent it back to the TAC.
Okay.
Okay.
And Sheila,
Kathy,
Kathy Adams has her hand up.
yeah, Kathy.
Hi, Sheila. I guess I'm a bit confused by the response because it says DMS will prepare with written guidance in the form of provider education. So I'm hoping that the language they gave us isn't all they're going to give us. Does that make sense? I'm hoping they're going to give us additional information and that they're just cut and pasting what they already have available in this letter, but that there's more to come. But perhaps we need to make sure that there's more to come.
Okay, that's very helpful, Kathy. That was kind of my feeling as well, because we were specifically asking for written guidance in the form of provider information, and getting the contract language with the MCOs. I'm not sure. In fact, we asked about how each MCO is implementing the process. I mean, part of what I think we were looking for was some guidance as well for providers if they feel like an MCO is not following those guidelines. They lay out the parameters in terms of how the MCO will notify the provider in 2 days through multiple modes of communication and the specific reasons for the review and so forth. And my impression from providers is that they're not always getting that notification.
Yeah. I thought we were trying to hope to some guidance of how a provider can respond to the audit and what recourse do they have in the process. Is that correct, Sheila?
That's what we had talked about. And I don't, maybe we didn't ask it in such a way that that was clear. And to your point, Kathy, it's been 2 months now since they sent this original response, and we've not gotten anything else.
And I do think that what they provided seems to speak, the majority of it is specific to prepayment audits. And I think we need additional information regarding the entire audit process. And then again, who do you reach out to when there's problems? You know, I know they've got that complaint form. And I know that Jennifer Dudinsky has, when she gave the presentation, was kind enough to offer up her assistance. So yes, I'm hoping we would get additional guidance from Medicaid on the audit process, because I have more to say, but our members continue to be inundated with audits, and just the difficulty in when you try to file an appeal, and we've got examples where the MCO doesn't follow the rules. They're required to respond to an appeal within 30 days. They can ask for another 15 days on that, but we've got examples, you know, of them not responding for 60 days or more to an audit request. And it's like there's no repercussions for the MCOs when they don't follow the appeals process. But if a provider doesn't follow it, they lose their appeal.
Yeah.
Yeah. Sheila, if I can jump in, this is Bart, real quick. I think the other piece is a lot of what we've received recently on the audits from Medicaid was around when Medicaid does an audit. But that's, at least my experience with our clients, that's a rarity. It's really the MCO audits. And when they don't follow the 30 days has been, I continually hear that, you know, there's that the provider has 30 days to respond, and they tell that to the MCO and it's basically ignored. So no, you have 12 days, or you have 8 days.
Right.
You know, it's just, so being able to contact someone at Medicaid to help get that resolved, and then we don't hear from Medicaid, you know, for months on end either. So I think it's really about the MCO audits and what is the recourse for, you know, I'm being repetitive here, but the recourse for the provider when the procedures are not being followed. Bottom line.
Yeah.
Thank you.
Can I jump in here as a provider?
Yes.
So in this, you know, and I realize this is directed at prepayments, but it says the MCO shall deny the claim when the submitted documentation lacks evidence to support the service or code. I have on my desk a recoupment request where WellCare is asking or is trying to recoup a month's worth of therapy services because the date of birth is not used as the identifier. So at our agency, you know, the only requirement is you use a valid identifier. So in our agency, we use the name and the social. And so to me, that also needs to be addressed. So timelines are an issue. We've had 3 or 4 audits since August the 16th. All of them have had 7 or 8 day turnaround times. And then also just like Kathy was saying there, the timelines for them to follow through. I have an example of one where we did an appeal and we didn't hear back for 7 months.
Okay.
Stuart on from WellCare. And I take it, who was that was speaking? I'm sorry. Was that Susan?
I think that was Susan.
This is Susan Campbell Turner with Children and Family Counseling.
Okay, and those were all regarding WellCare, is that correct?
The one about the date of birth was WellCare, and we've also had 3 or 4 audits from WellCare since August the 16th. Yes, the one about the 7 months was actually not WellCare. So
okay, all right, good. So
congratulations.
A little bit of information there. So that particular audit that we've done it's ending September 23rd. And it should be, we definitely give 15 days. I believe we've agreed to do 8-day extension as well. And I know there's an option to do remote. There's several options, but one of them is to do remote, where if you permit, it's our vendor, access to your system, your EMR system, they can actually do it. They can pull it, do the, the legwork, so to speak. I mean, so that's definitely an option out there. But you can ask for an extension, as well, but it will end September 23rd.
What ends September 23rd?
This particular audit, this particular audit, medical record audit, is of behavioral health providers, and it's with a vendor named Datavant.
Is this the risk analysis?
Yes, risk adjustment. Basically it's critical to capture all the diagnosis. That's one of the things in care management, for example, making sure that that we capture all the diagnosis for all the members, so we understand their acuity, can refer them to case management, for example. So it's critical to know that.
And Sheila, what Stuart is speaking to is the information that the Children's Alliance has gathered from their members on this particular audit. I don't know if you're ready for me to talk about that yet. You may want to get a little further down. I'm not sure. But just let me know when you're ready for me to, I guess, kind of respond to Stuart about this current audit that's going on with WellCare.
Well, let's go on and do that. That's the
Yeah.
number 5 on the agenda, follow up on audits. And Kathy, I know that you had gathered some data, and I see that Jennifer's on from Pathways and has also been in touch
It's had the
with
same situation.
same situation. Yeah. So Kathy, you want to talk about your data while Stuart's on here?
Yes, please. That would be wonderful. So the Children's Alliance started hearing from members in I guess around August 19th, 20th, around that time frame, that they were receiving all these audits from WellCare. And so the Children's Alliance reached out to who we work with, the WellCare reps. We had gathered some information, expressed our concerns, and that's when we were advised that folks could have a 15-day turnaround instead of the 8-day turnaround. But just compilation of the information that we received from our members to put in context the burden of some of these audit requests that are being placed on providers. We received feedback from 9 of our members, and 53, they had received 53 different requests on behalf of WellCare participants within the last 10 months. And at least 35 of those requests were received within 7 days during the month of August. 53 record requests asked for records for 1,744 clients. And we're talking that they're asking for at least a year's worth of records. In some instances, it was up to 18 or 20 months worth of records. Of the 35 requests that were received in that 1 week in August, they asked for records of 1,302 WellCare clients. And again, most of the time frame requests were for a year, but some went up to 18 to 20 months. So we have had difficulty finding out the purpose of all of these audit requests and why so many records are needed. The only explanation given is that the purpose is to collect all current diagnosis codes in the patient's medical chart to best ascertain the health status of the patient. So we have all these providers scurrying to pull records on over 1,700 clients, and that's just from 9 of our members. It's my understanding that all kinds of providers have been hit with these requests. And so again, we had members that had difficulty when they reached out to Datavant to request an extension. Many did not want to grant an extension. And we do appreciate the 15 days, but we had some members that had over 190 client records requested. And you can't pull records for 190 clients for a year in 15 days. You just can't do it.
No.
We've not had any positive feedback. They send all this information in, and it's like it goes in a black hole. You never get any response on what you could be doing better, any of that. So it's just, again, this is just one example of WellCare audits. In the meantime, our members have other audits coming in. And again, we are concerned with the frequency of these audit requests, the number of records being requested, the short time that providers are being allowed to provide the records. It's like they don't have anything else to do. The extensive audit timeframes that they're requesting, 20 months worth of records, confusion and duplication in the records that Datavant specifically requested. We had some members that got one request for 145 records, like on August 16th, and then the next week they got another request for 145 records. They've had others where there were duplication between those that they requested, and it's been very difficult in getting responses from the Datavant representatives. And then again, just the confusion around why are we having to do all of this. So I think that kind of summarizes the concerns, but we have gathered all of this information. I have compiled the information. I have provided it to our WellCare reps. I have provided it to Sheila as the behavioral health chair, and I've also provided it to Medicaid.
Thank you, Kathy. I see that we have Dr. Patel on, who's the Chief Medical Officer of WellCare.
Yeah,
Welcome,
hey.
Dr. Patel.
Yeah, thank you so much. So let me first start by saying we, WellCare, apologize putting undue, extensive, and so much burden on the provider. That's never the intent, right? But let's just talk about how we got here, right? There are no BHPAs, right? So we don't have a very good ability on our side to understand practice patterns, understanding if our members who we are, responsible for being good stewards of the state dollar, that is our role. We have no ability to see that, right? And so this audit, while it appears extensive, and it is, and like I said, I apologize for the undue burden, it helps us better understand if the whole cohort, the whole panel of BH providers in this ecosystem are practicing evidence-based guidelines, doing what's in the very best interest of the members that we are put instead of. And it helps us understand, should we be advocating for more services or having discussions with DMS about maybe some services are being overutilized or maybe they're being inappropriately utilized. Are we seeing the clinical outcomes? And so while you guys are delivering the care at the point of delivery, we are also in the background making sure that the several 100,000 members that we're all, here to serve are getting the right thing. And we're not the only ones doing this, right? The other MCOs are doing this as well. And so while I appreciate you calling us out, it makes me feel pointed and special. We're not the only ones who are doing this.
Yes, they are.
If I could respond, I'm not hearing complaints from my members about any of the other MCOs requesting records to this extent at all. And then that was, in fact, one of our questions is if this is required of all the MCOs, then why aren't providers getting these requests from the other MCOs? I have a couple of examples, but my examples are they're requesting 1 or 2 records.
In
Not
response to
100
that, I would say WellCare, as a steward of the state's dollars, it is our job to have the extensive rigor and due diligence around ensuring that the members that we serve get appropriate, timely, and correct services. And that is the essential reason for the audits. Once again, and this will be the last statement I make, we apologize for the undue burden that we cause providers, but that is the reasoning for which we do what we do.
Well, let me ask you, Dr. Patel, and thank you for being on, and we appreciate the apology. I guess my question would be, when we hear from providers that they have asked for extensions, for instance, and they're not being granted, do you have a response to that?
Yeah, I do. Respectfully, we can take each example one by one with the provider. We can give you a number today. Beth, can we make sure we have a one-to-one contact and we can handle that? Respectfully, I don't feel like it's appropriate to bring a individual complaint about individual cases in a forum like this. If there are individual cases, I think Stuart, myself, we've always made ourselves readily available to contact expeditiously to help make sure we expedite the care of a member. We've never been a barrier to the care. And so while you're saying that you have examples, we've not seen the examples.
But you asked for the information, Dr. Patel. So, I mean, you know how much the volume you've asked for. What percent of people accessing behavioral health services, they're being audited, 12, 18, 20 months, and you acknowledge yourself it's an undue burden. I mean, you've said it yourself.
So,
is there a better approach, a better way to do this that you can, because
yes, there is a better approach. There is. We have in multiple venues asked for partnership to think about having certain parts of PA turned back on. We have talked about different mechanisms of oversight because there is not any PA. So this is not.
But have you thought about a sampling methodology that doesn't have this large volume and has sufficient time? Because I think if the data from Kathy, and I've heard similar data from CMHC, it's very comparable. Pathways is on, they've had the same, I think it was 400 plus records.
We're now at 800.
How many?
We are over 800 records.
800
for one
records.
agency.
800 records from Pathways.
Respectfully,
go ahead, sir.
We're doing what we think is in the best interest of the member. Okay. And I think we can take back a different methodology. And we said that this is ending September 23rd, right? So there is a time-defined endpoint for this. In the next round, because obviously at some point, one day in the future, cannot determine when, there will be another audit. We can ensure that the burden is not untoward. However, what I will say is there was a reason that this was done. There was a data elements that we wanted to see to ensure that, again, putting the member first and the responsibility of the MCO, which is to be a good steward of the tax dollar of the Commonwealth, to ensure that our members are getting the right service at the right time and the right amount, which is what we are here to do, is part of the reason for the audit. And so it's my full belief that all of us need to be fully engaged in that exercise. And because there is no ability for there to be BH outpatient PA, we're not all fully engaged in that process. And so I apologize once again. I think this is the fourth time. We are definitely apologetic for the burden. However, this won't be the last time that there will be an audit.
Right. So, I mean, I appreciate you being apologetic, but the reality is we are fully engaged in the process by submitting you hundreds and hundreds. If you look at them, 2 CMHCs, Adont and Pathways, 1,400 cases, 1,400 files. We are very involved in the process. We're just thinking this is, again, an administrative cost. It diverts licensed people, staff away from their duties to perform these functions. Okay? I just think this is a venue to discuss, as opposed to just using prior auth, which is the answer that you're putting forth. Do you need 800 files
So
to
I
determine the
agree.
pattern? Do you need 600 files to determine the pattern, right? Can you send well care staff on site?
We can.
I think that's, again, a mechanism to move forward, that they can participate. In reality, and I've said this for years, this has become a huge function that we're copying records, we're sending files, we're sending information. There has to be a better way, and there has to be a more effective sampling method than this large volume. It has to be a different way.
Real quick, I want to say real quick about the on-site. We actually do. I'm looking at the letter. We offer to go on-site. Just as far as that, we actually do offer to go on-site and do that. We also offer remote, where if the provider gets access, then DataVant will do the actual retrieval. So I mean, just putting that out there. Those are a couple of options that's in the letter.
And I'll end with this. I appreciate, I acknowledge everything you're saying, but let's just remember how we got here. The BH outpatient utilization in Kentucky is one of the highest in the country, but yet we don't see the clinical outcomes to match. And in our due diligence to find out why this is occurring, well, we have many hypotheses. You probably have hypotheses too, but in the spirit of trying to get to a place where we have appropriate utilization for the appropriate service for a great outcome for the citizens that we are responsible for, we are searching for data. Again, we are several
You're
hundred.
getting data. You're getting data. There's no need to search. I just think
I will end my
it's
commentary.
burdensome. It's burdensome, and it takes away from the mission of behavioral health organizations. And if
But you don't have any response
in
to
states, maybe we do. That's because we focus more on their individual needs and we try to move forward. We can debate this for a very long time. I just think, again, excessive number of records in a short period of time with no feedback provided. What is it? It doesn't seem collaborative to me.
I'll end with let the record reflect. WellCare has formally apologized for the asserted burden of the pulling of the data files.
And we appreciate that, Dr. Patel. I guess we're a practical, let's work together for solutions. And while this may end here in about 2 weeks, it's going to come up again.
Yeah.
And we're just trying to figure out a way to avoid this excessive burden, as you have described it, and we appreciate that, while still all of us wanting the outcomes and so forth. Bart, I think you had your hand up, and then Nina, and then we'll probably move on. Bart?
Yeah, so just point of clarification, I think I think that's what we're looking for, is a solution and a commitment that the excessive work burden won't be there in the future, so we can find a better way to gather the data that is in the due course of the delivery of services and the billing, but it doesn't require such excessive time. And I want to go back to a comment you made, Stuart, a couple of times, just for clarification. Your comment around a remote. Explain that to me, what you mean by a remote?
Yeah.
You mean
yeah.
that they would access the medical record system within the provider? Is that what you
Yeah, they
referencing?
would,
Is that what you're-
yeah, literally the vendor, because I'm looking at the letters, like you contact Datavant and set it up. You actually set it up, Datavant, where you would give them, the provider would give them access, Datavant. You know, maybe you have concerns about that, but that is an option. Literally, it
I
says
do.
contact Datavant about how to do that. And so then the Datavant staff would pull the records. And then it does mention as well, on-site chart, reviews, then come on site and do it as well. But I think the remote thing, I don't know if anybody's tried the remote thing, but it's an option. I mean, I'm, looking right at the letter. I mean, you would have to have staff that, gives them access there and sit there. But the data van would do the retrieval of the medical records.
But you can't do that without opening up your entire system.
Correct.
Right. I mean, you'd have to, you'd have to sit there and open up, give them access and everything.
Yeah.
Okay.
Sounds like a breach.
Well, I hear what you're saying. It's an option, but I don't know how realistic that is in terms of somebody willing to open up their entire, digital medical record system for everybody, not just for this, because you're getting clients that aren't WellCare clients there.
It says secure. I mean, it says secure. And I, honestly, I don't know the details, but it said to be secure. I'm sure it'd be HIPAA compliant. I don't know the details, but I mean, it does say secure remote EMR retrieval. That is an option.
Okay.
But I honestly, I don't know the details.
Okay. Well, it's worth digging into, but it sounds like it's not being utilized.
Right.
So,
yeah,
okay.
I'm assuming it is not, but yeah.
I mean, I can tell you that our attorney said absolutely not.
Right. And if not the
Because
attorney, the
HIPAA
IT guy, right, Jennifer?
Yes.
Yeah.
because of HIPAA concerns.
Just,
HIPAA.
yes. I mean, there's no way to let you just into certain charts. You're in the entire EHR.
While we're on this, I see this from Tracy, but I've also heard it from numerous other providers that when they have tried to contact Datavant about any questions, Jennifer, I think you had this issue too, they are not responsive. So if
Rita Harpool, her comment as well. She's been trying to raise her hand. I
Yeah.
wish I could figure out how to do that, but Datavant doesn't even want notes from mental health providers.
Hi, I'm Dr. Harpool with Hope and Healing in Western Kentucky. I'm sorry, I couldn't figure out how to raise my hand, but
Sure.
I just recently learned this. And I mean, after having all these chart reviews, I've contacted Datavant several times during these chart reviews, but for whatever reason, this was the first time I had been given this information. The representative wanted me to have the notes or have the information turned in a certain period of time. I told her that just wasn't possible because I'm kind of a one-woman show here and it wasn't enough time. And I explained to her how many notes that would be. And she said, well, what kind of doctor are you? I said, a psychologist. She says, oh, you're behavioral health. You don't need to turn in all those notes. We don't want all those notes. She said, what we want from behavioral health is we just want for each client each patient that we listed, send in a one-page summary that has, she gave me 4 items that needed to be in the summary. A diagnosis, a functional treatment plan, if it existed, a prognosis, and there was one other thing, which I can't remember off the top of my head. And I told her, I said, well, that would be very helpful to know because that's going to save me a lot of time. I said, I've never been told this. I've been sending in all these notes for all this time now. And I said, nowhere in your 4-page document that you faxed me requesting this information, does it say anything about behavioral health needing to provide it in a different kind of format. I said, nowhere does it say that. I said, actually, what you keep sending me appears to be material for a medical doctor. And she's apologized for it not being in the paperwork. And she said, yes, you're correct, it's not. And I then requested that they send me something in writing saying that this is all that they require of me. I haven't received that yet, but this conversation just happened last week. I went to the MCO, the Medicaid form in Owensboro, just this week on, I think it was on Tuesday. And I talked to WellCare there about that as well. And I spoke with Medicaid about that. But that's information I certainly didn't know.
Yeah.
Yeah, and I'm looking at the letter, you know, request the medical record to ensure that properly reflects the clinical conditions. So, I mean, it clearly says the record, but diagnosis, what you talk about is number one. I mean, it doesn't say anything about a summary because it's got to be documented in the medical record. I mean, the diagnosis, I would think, has, yeah.
And doesn't WellCare get the diagnosis on every claim that's submitted?
Yeah.
If it's reported, not, you know, not all diagnoses are reported. We absolutely see that, where they don't report the diagnoses. And I think that's part of this, is looking at the medical record. Is there indication of a given diagnosis, but it's not captured, you know, in the claim? We absolutely see that. I know where our providers may report, you know, the primary diagnosis, but not secondary or third diagnosis, for example.
Let me go to Nina because she's been very patient and has had her hand up for a while.
Thank you. You know, I'm sitting here listening. We don't do as much outpatient work as we do inpatient, but it is the responsibility of the payers and the providers to ensure that the medical care that is provided, the behavioral health care that's provided, is appropriate to the patient and verifiable through the criteria, either SAMHSA or other criteria. I'm just wondering, based on the fact that there was a comment from someone at WellCare, I think it was Dr. Patel, that you aren't seeing outcome data. The hospitals working with CMS on the HRIP program came up with a variety of outcome measures which are required to be reported on a very regular basis and are the basis for continued ability to secure the funding and participate in the program. And I'm wondering if perhaps the MCOs and some of the providers could come to terms and, you know, audits are going to happen. The last thing I want to see happen is go back to prior auth for behavioral health. That was a nightmare. But I think that we have to come up with some way to verify and report that our care and treatment is appropriate and achieving the outcomes that are determined to be proper and required. So I guess just as a way of kind of tying it up in my mind, I'm wondering if that might be an important step.
Yeah, I can respond to that if you don't mind. So that's a fantastic point. There's two types of outcomes, right? There's the clinical outcomes that we would measure, you know, as a total clinical outcome, right? Like, hey, did they have a readmission, or did they, you know, get better from their diabetes, like a chronic condition management, right? And I think in BH, sometimes that's a little harder to measure, but there are definitely NCQA-based patient-reported outcomes. There's a bunch of things that we could all agree upon. We've never gotten to that point because I think we stay in the weeds instead of going macro sometimes as a group. And, you know, what we're seeing on our side is exponentially increasing utilization of what we would call lower level clinical services, but very important services. Nobody's disputing that wraparound lower level clinical services are not important. They are very important, okay? But what's equally important is that core clinical service has got to be gold standard, okay? Yeah. And what we're seeing is the core clinical service is not always evidence-based. And then the wraparound services are increasing, you know, exponentially, like SpaceX, right, to the moon. And then what we're seeing in return is not a decrease in inpatient utilization, in ER utilization. We're seeing often polypharmacy. We're seeing tons and tons of adverse utilization. we have tons of kids on psychotropics, multiple psychotropics without one of the medications at an sufficient maximal dose. And so that's not good clinical care. And for us to make sure that, nobody likes to hear this, fraud, waste, and abuse, to make sure that our pediatric members are not on polypharmacy, our adult members are being navigated to the right long-term destination of care, because these are long-term patients now, right? Are they getting the right long-term level of service, not more and more service? And so, yeah, we would love to have an open discussion about these things, but for us to have a good barometer of what's actually happening in the marketplace with our members, we need to have some insight. And the audit, it really is the only way for us to have that insight without having some circumscribed level of PA on for outpatient BH services. It's my purview that if we had some, not all, outpatient BHPA back on, that the level of audits would go down exponentially as well, because then we'd have dialogue around which services should have PA, which should not have PA. Can we, auto approve things that are really high level, important to our members, things that we're not seeing good outcomes for? Maybe there needs to be PA for. There can be back and forth dialogue. Right now, it feels like we're at a total impasse. And the thing that we're arguing about is the level of audit and the burden of the audit, which we realize it's burdensome and you realize that it's cumbersome. And we want to get back to talking about the member. We don't want to be mired in talking about the audit. We want to focus on the member. And right now, we're not being member focused.
Yeah, and to add on to that, Nina, particularly what we would like to see is very targeted prior auth, like specifically peer support, psychoeducation. We literally have a lot of providers, especially in the addiction sphere. And we've hundreds of new providers have come in and have exploited the lack. We've even asked for authorization after a threshold, but very targeted 2-3 services, because we have providers who that's what they do. No matter what your diagnosis, you're addicted to heroin, cocaine, you've had a fentanyl overdose, you get a ton of peer support, you get psychoeducation, maybe a little something else. You're not getting clinical treatment, and the outcomes are worse. And so it's very targeted is what we're wanting, what we're arguing for, not everything.
I mean,
I think we could come to that. I think we could come to that. I mean, one of the metrics, for example, in the hospitals is no one gets discharged on multiple antipsychotics. There's another one that talks about ambulatory follow-up post-hospital care within certain number of days. And so we could even marry some of the more higher level outpatient services to be in correlation with some of the hospital parameters for ensuring evidence-based, clinically appropriate care and the outcomes that the DMS also wants to see as we try to move the metric on a healthier, population overall, both medically and behaviorally. So I would love to participate in, I'm more of a neutral party, although I won't be neutral if you talk about reinstating prior auth, but I think just get a cadre of people together to work with WellCare and to work with DMS on really coming up with what are the quality outcome measures that we want to see for various levels of care, not just hospital care.
So you tell us where to be, Stuart, you tell us where to be, when to be, we will be there in person, okay? But we have a guardrail as well that this premise that more is better, unlimited access is better, that's never been borne out to be true anywhere in the United States, especially in population health for BH. So as long as we can agree to, a certain set of facts and not be in an echo chamber, we will be there open-minded.
Yeah, and a note, like literally the ones, it's a business model because the peer support, it's paraprofessional care, it's low wage, high profit margin. They have invaded and are choking out. We have very good behavioral health providers who give clinical care, and the ones that have that business model are choking out. And actually, they're very aggressive in marketing to members, and that's like what we're trying to address. We're trying to get our members to the good providers, to the clinical providers, and that's that's why we want targeted PA, and not being able to do it has prevented us from being able to, help our members get to the good quality providers or giving clinical care, or at least mixed in.
But
So
if you're
are you-
concerned about those services, are you auditing all services? Are you auditing all providers? You're citing those as your concerns. Are those providers the first on the audit list?
For
I
the
don't
data,
think the answer to that question is yes. I don't
Right,
think the
yeah.
answer is yes. It is a
Yeah,
across the board.
Steve,
It's
yeah,
not
Steve,
a strategic approach to the audit process to address a concern you cited. It's not that. It's everybody. I'd love to have a conversation on how we move forward. I think that's a great idea. But let's just acknowledge you are looking at across the span of behavioral health providers. You're not looking at the ones that you are concerned about with psychoeducation services, peer support services. Are you? I mean, doing those first? I don't know.
no, yeah, no.
So,
Yeah.
There needs to be a good
Well, we're-
dialogue, give and take, but let's just acknowledge it's across the board. I'm occupying too much time. I apologize.
Okay, this has been a great discussion. We appreciate your being on, Dr. Patel, and engaging in dialogue.
Good work.
And we will kind of take this back and figure out how to go next. I don't know that, well, I mean, we've talked about well care. Obviously, you all are not the only ones doing audits, and if we're going to institute some metrics or talk about some metrics for knowing what the outcomes ought to be, it should be across the MCOs and outpatient. But I guess I'm going to follow up with what Steve said to you, Stuart, and that is if you know who the offenders are, I'm not real sure why people that are not doing SUD or not doing the bulk of SUD services are being audited to the extent that they are. And I'll just leave it at that.
Yeah, we have done some, and we're actually prepaid review, which I think is on the agenda, and we're looking at that. And we actually have lobbied for a lot of things and had very little success because we want targeted PA, or at least off after a threshold and limits, and we keep getting rejected. And we think that would really be critical and would stave off, the audits, because everybody hates audits, and audits don't help. I mean, ultimately, that's what we've been told is you can audit, but the member's already gotten the service. And if it's something that they didn't really need, but anyway, we've been trying.
I would just find, in my conversation was suggesting that as the behavioral health providers on this phone get together with the MCOs or DMS or whomever else, that provider representation from the hospital psychiatric and addictions treatment forum also be included, because there are many of those organizations that provide the continuum of care. And, I think that hospitals have become pretty good at, not to say that you all aren't, that outpatient isn't, but ensuring that there are criteria before a patient moves into a certain level of care, and that there's monitoring for how much of that care is provided at that particular level. So I offer myself up, but I'm sure that there would be others. And I would just leave it to say, by the way, I used to serve on the WellCare Clinical Advisory Committee, and it was a pretty robust organization or group and diverse in its membership. And perhaps something like that, not just with WellCare, but perhaps for the MCOs globally, because WellCare is not the only group with a responsibility for fiduciary and clinical quality monitoring. So.
Right. Let's go back to number 4, which is our discussion of phase 2 multi-state study. And I shared with you all the recommendations that the BH TAC sent in. Is Victoria on?
Yes, ma'am, I'm here. I am going to share my screen.
Thank you, Victoria.
And I'm going to share what you sent to me, Dr. Schuster, and I thought we could walk through and just add some notes to this. I think we can take it back and expand on this a little bit. The number one completion, going back and adding that MD level shouldn't be a problem at all. We have all of those fee schedules. We've captured those, and going back and looking through them, great idea. We can definitely do that and then run the analysis again. If the ABA or the Children's Alliance would like to send us any published fee schedules that they would like us to use it for consideration, we would be happy to take a look at those. Again, we're looking at fee for service, and we're looking at non-population specific analysis in that phase 1 piece. As we move into phase 2, there's been some suggestions to add different populations and whatnot, and we can look at that. But to go back and complete phase 1, we will be doing exactly what we did before. We'll just be adding the MD level practitioner to that analysis, and then we'll rerun those tables. So anything you want to forward, if you could forward them either through Dr. Schuster or Erin, I think it's a cleaner way to communicate so that everybody kind of has it forwarded to us.
Yeah, let me just say, excuse me, Victoria, if you'll send it to me at kyadvocacy@gmail.com, I will gather. That's what I've always done. And then it keeps the flow of information straightforward. Thank you.
Yes.
Can I ask if you received the information from Michelle Sanborn with the Children's Alliance? She's not able to be on today.
We have received several grids from the Children's Alliance, and we've also received resources from the ABA. Some items that we've received didn't match because of those things I explained the last time. We're looking at something very specific in this phase 1. We're looking at fee for service, and we're looking at a very specific practitioner level. Some of the information that was sent over by Children's Alliance and ABA were population specific. And as I explained in the last presentation, we didn't do that in phase 1. We're not opposed to doing that in phase 2, but that wasn't part of the phase 1 work. So anything that you'd like to send to us, if it's not straightforward fee for service, fee schedules from the states that are included in the study, then that would be added into the phase 2 work when we're looking at specific populations. You know, does SMI pay more than, a behavioral health diagnosis, or SUD pay more than just a behavioral health diagnosis? Those types of things then would be added into the phase 2, if that makes sense.
Yes. And is it possible to have a conversation with you or whoever helps you about what we sent to find out what works and what doesn't?
Okay, what we're using is fee for service fee schedules off the Medicaid websites of the states we're looking at. And then so we're not looking at any kind of added bonus for a particular population, or like, if you remember the phase 1 study, there were some rates that we found in other states that had a bump because of a Senate bill that went through that state. And they focused on a set of services and said, we're going to pay more for those services. Well, we didn't include those in phase 1 because we don't do that in Kentucky. So we're looking at apples to apples as much as possible in the phase 1. Phase 2 is going to move into a little bit different scenario. We're going to look at it a little bit differently, if that makes sense to you guys. But we're gonna go back to phase 1, add in that MD level. That's not a problem. I already have all of those resources, and that should be a fairly quick task. Once we do that, we are not opposed to adding to this list. You know, we suggested that in our phase 1 presentation. So this second set, this deeper dive into these services that show either higher or lower in another state, taking that deep dive. And so we do anticipate that these 6 services, this number of services may grow. And so, yes, we will add to that. Adding Illinois and Missouri, absolutely. Like I said, my bad coming here from out of state. In my mind, I thought I had all the touching states, and I didn't. So yes, absolutely adding Illinois and Missouri.
Well, they don't touch much of Kentucky, so it's understandable.
But Tennessee, we still have an issue with, and I wanted to talk to you about this and help you understand. if we add Tennessee, we would have to go back and redo phase one and look at MCO rates, because you can't really compare an MCO rate to a fee-for-service rate. And then, as you know, if we looked at MCO rates, because of that negotiation thing that happens, we'd have to look at a lot of averages. I don't think that's really going to give us a robust analysis and really tell us what we want to have. So I'm still opposed to adding Tennessee unless you can give me a great argument, because it's not going to, you're not going to be looking at the same thing. You're going to be looking at two different types of rate. So saying whether one is higher than the other one doesn't really matter, because they're two different types of rate. Does that make sense, Dr. Schuster?
Can I
Yeah.
comment on that?
Yeah. Bart, you've raised this issue. Do you want to respond or ask a question?
Yeah, just I think the issue and the lens, I think it gets to, Victoria, the lens, you know, the questions at the end of why do the study. I mean, I understand that there is a difference between Medicaid fee-for-service rates and MCO rates, but the purpose, at least in my mind, the purpose of all this is to do an evaluation and an analysis of, are the rates in Kentucky adequate to meet those four questions below? And 7 border states is a big part of that issue, competing for staff and compete around the border states. And Tennessee is majority of our southern border. So I realize there's fee for service and there's MCO, but the reality is the MCOs are what pay for these services in Kentucky.
And I understand that.
Well,
and maybe by the time can I get through the whole thing and then we'll come back to that, Bart? Because I get what you're saying. And that brings, like, as we walk through phase two, so far what I'm talking about is just adding to that comparative. Does this rate pay more? Like, does a half gallon of milk cost more in Kentucky than Tennessee? Okay, we might be able to get there in phase one. But phase two, you're really morphing into a different type of study. This is no longer a rate analysis or a rate comparison. This is an analysis about access. And rates are only one part of access, right? How far I got to drive to get to my provider might be a part of access, and how many providers in my area might be a part of access. So if we want to, in this next phase of this study, look at barriers to access, I think then we have to really design a more comprehensive study that includes much more than just rates, right? If we really want to understand access to, or barriers to access, we can do that, and we can look at that very robustly, and then we can say, is it rates? Maybe rates are a component of that, but maybe how far I have to drive to get to my provider is another component of that. Or maybe the number of clinical practitioners at the level that I need is one of those things, right? So I think to answer these 4 questions, this no longer becomes a comparison of, does Tennessee pay more than Kentucky? To answer these 4 questions, I think we have to really develop something more robust. I met with Dustin Wallen this morning, and what we'd like to do is take the next several weeks and design that study for you, develop a study that would answer these questions for you, as well as some other questions. Now that we understand that what we want to really, the real question is, are people having a barrier to service for any reason? Is it how much we pay our providers, or is it how far they have to drive, or what is it, right? So that's gonna, if you agree that that will be where we go next, I'd like to say that maybe over the next couple of weeks, you funnel up to Dr. Schuster any other outcome questions we could add to this list in that type of analysis. And then what we'd like to do is take that back and design that study, bring you that study plan at the next TAC to get your yay or nay on it. And then we'll deep dive into that and get you guys the answers that you want in that respect. Does that make sense, Bart? Because I didn't mean to cut you off about the MCO and the fee-for-service question, but to answer these 4 questions, I do believe it's much more than just who pays more, right? There's a lot about access.
Right.
Sorry, this is Mandy Marlar. I'm sitting here with Bart just off screen. He gets the limelight. But want to say to thoroughly appreciate the thoughtfulness that's gone into what phase 2 might look like and how it might comprehensively tackle those 4 questions. But don't want to lose sight of the fact that as we're looking at those other factors, like whether or not you have a provider and driving distance, whether or not that provider can be staffed, we do think those are largely dependent upon on rates, upon the resources we have available to
And
open.
absolutely, I mean, we're not saying to take rates out of it, Mandy. That phase 2 work would be folded into, or that phase 1 work would be folded into the phase 2 work. But all I'm saying is, you can't answer the question, is it a barrier to service? Is a rate a barrier to service? Because that may not be the only barrier to service, right? I'm just saying we have to incorporate the rates as well as some other things. So definitely rates would be looked at in the phase 2.
Yeah.
Let me suggest a little bit different way of looking at this, because what you're suggesting, Victoria, I think is where we want to get eventually. I guess I see an in-between step. I think what happened after phase 1 was that you identified, and then we identified some tweaking of that first model, that comparison model. And there were some services that were left out. You know, you've mentioned the 6 here, you know, certainly the IOP and partial and therapeutic behavioral health services are others. Bart's group is certainly interested in some of the ABA services. And there's some question I think that we had raised about, are we doing apples to apples in terms of who's providing those services? Because I think there was a little confusion initially about how we were defining the providers. So I guess I'm wondering if
and again,
if we might add these services on the list here, these 6, and then also IOP, partial and therapeutic behavioral health services, and maybe there's 1 or 2 others, and kind of go back to that phase 1 model.
And to be clear, Dr. Schuster, phase 1 will be refreshed looking at all those things on the top of this sheet. Absolutely. We are going to refresh phase 1 and look at these again with the suggestions that you've given us.
Okay.
I do want to point out, though, IOP, partial hospitalization, and therapeutic behavioral health services were included in phase 1. There were just some states we could not compare them to because they provide them so differently than we provide them. So they are on those original tables, and wherever we could find where the service definition matched, then we compared. So you do have some comparison there. We don't mind doing that analysis of why specifically they didn't match. We can definitely do a grid that says, you know, why we didn't feel like they were defined correctly, and add those richer definitions in a subsequent. But I didn't mean to get off and misstate this, but we're looking at phase 1 refresh to include all of these concerns you had. Adding those additional states, re-looking at those numbers, those codes that you wanted us to look at, like looking at those things. Populations are still going to be tricky because as like our fee schedule doesn't give an additional dollar amount for a specific population. So those are still going to be difficult to compare, but we can certainly add them to the grid. We're just going to organize them a different way. So phase 1 will be refreshed. We'll look at the MD level. We'll add the extra states. We'll add those additional CPT codes, do a deeper dive, give you a better analysis of why we didn't feel like IOP and partial hospitalization matched up. We're definitely going to do all of that work. The only thing I'm trying to point out is answering these questions based on rate alone will not give you an understanding of access or barriers to access. And so I would just recommend when we get to that part, we really look at it comprehensively, instead of just saying if we paid more, then more people would have access, because I don't think it's
absolutely.
That makes sense?
Yeah. Yes, it really does. I just wanted to be sure that we were not losing these additional services. And
no. We're going to compare this.
So we're really going to have a phase 1 refresh, you're calling it. I think that's a good way to look at it. Same MO, if you will, same study design, but with additional states and the physicians and the additional services.
Yes, and
And
give you,
then
I'll
what
give
you're
you a better
proposing-
analysis of why
Yeah.
we couldn't match these.
Why you
I'll let
couldn't
you
match up
understand,
on
instead of
those,
just saying
yeah.
they weren't able to be matched, I'll give you a better analysis of that.
Yeah.
So that would be part of our study plan, the phase 1 refresh. And
Okay.
then the phase 2, what I'd like to suggest is if y'all could spend the next little bit thinking about what else you might want to include in that phase 2 to answer these questions, or maybe we want to add a couple more questions to that second analysis. If you could get those to Dr. Schuster by September 30th, Dustin Wall and I are going to sit down and design this for you. And like I said, bring it back to the TAC and make sure we're covering all the bases, make sure we're looking at it the way you want us to. And I will bring back as much of that refresh as I can. We might do that phase 1 refresh in stages, because I do believe I can do some of that fairly quickly because I already have it. It's just a matter of plugging it in and then having Oda like rerun the data for us. So that I may be able to get some of that phase 1 refresh by next TAC. I'm not going to promise, but I'll work hard on it. But then we'll come up with that plan and let's show you how we're going to look at it to make sure you're all on board and we're not missing any steps. And then once we get your blessing, we'll start that. I am going to tell you that a study like this is going to take months. This isn't going to be a quick turnaround. We work 6 to 8 months on phase 1, and we're probably looking at 6 to 9 months on that phase 2 analysis of really digging into some of those barriers to access, even in terms of rate, right? And we will take the Tennessee question back. How do we include Tennessee in that phase 2? That access, that is rates in Tennessee causing access barrier questions for our Southern folks. We will bring that into phase 2. I just don't think it can be included in phase 1 because of the way we did the analysis. We would have to start completely over if we wanted to look at MCOs rather than fee for service. Is that good with you, Bart? Is that a good compromise?
No, that's fair on the phase 2. I just wanted to point out that if we can find a way, because of the border state issue, to include Tennessee in that analysis, that would be helpful. And before, I know we have a lot of people with their hands up, so I don't want to dominate, but I do want to answer your one other green question you had on here, Victoria, around the primary ABA codes 753 and 55. That was not meant to be a specific population. No, that is
just for
ABA
any kids.
code. Any age.
Any
in
age.
Kentucky.
Yeah,
in Kentucky, and I think this is one of the things in Kentucky, licensed behavior analysts are in the state plan, are primary Medicaid providers, so they can provide ABA services within their scope of practice to any age population or any diagnosis. It's not just children, even though it's obviously ABA is closely tied to young children with autism, but in Kentucky, it is there are no age limits or diagnosis limits in Kentucky in terms of providing ABA. So other states, they fund ABA for children with autism diagnosis, 21 or 18 and under, but it's still the same code. So so our intent is not.
Well, it is the same code, but remember, we didn't compare codes, Bart. We compared services. So
well, so it is the same service, so it is ABA.
And what we found though is some of those codes, the 97153 and the 97155, they got bumps. They had a state Senate bill in the state, and so they got special attention. You can't compare that to what's in Kentucky. Then make a note that state chose to identify that as a concern and gave special attention, but you can't really compare it, right? Because they pay higher, but they pay higher, but so again, that's in the analysis, that's not in the comparison.
I would say maybe not in phase 1 you can't compare that, but I think in phase 2 you could.
Absolutely. I think what I need to help you guys understand is we compared those codes. They were left off the table because they were not an accurate match. So I think what I need to do is add why they weren't a match into the analysis for you instead of just eliminating them from the table, which is what I did. Again, phase 1, we were asked to compare rates, period, apples to apples. Does this pay more than that? Understanding what you're really looking for has helped, because I think in this phase 1 refresh, we'll be able to give you much more information about why something didn't end up on the grid. So you may have found it on a fee schedule in a state that we looked at and we left it off the grid. And y'all are going, why'd they leave it off the grid? Well, we left it off the grid because the definition was different, or there was some kind of special circumstance that Kentucky didn't have. So that's the part of the analysis I want to bring into that phase 1 refresh to help you guys understand why we didn't do the comparison. So it's part of the conversation. It's just not part of the comparison. Does that make sense?
Yep.
And I apologize because I looking back, I wish I'd have added all that to phase 1. But again, I was just saying, does Kroger pay more for milk or does Save Mart? You know, like which one pays more? But now that I understand kind of some of the nuances, I will definitely bring all of that into the narrative, into the next, into the phase 1 refresh to help you guys understand what we looked at. Because you're right, maybe that is something that we look at in Kentucky, that this particular population needs some special attention. You know, I don't know. I'm not the expert on that. All I can do is bring you the information, but I will do a better job of explaining it in the phase 1 refresh.
Let me go on, Nina, and then Dr. Patel and Kathy, and then there was a question in the chat about having somebody from each discipline be a part of this. And let me just say, as you all can tell by having 134 people on here, I run a very open TAC, and anybody can join, and we entertain input from people that are not voting members. So anybody that wants to weigh in on this and send me information or whatever, I'm open to receiving that. So let me go on and ask Dinah about her question or suggestion.
Just a quick question. Rates, I want to know, did DMS publish an updated BHSO-AODE rate schedule in 2024?
That I would have to find out for you and find, is anybody on from BH that could answer that question?
Or does anybody else know? I haven't seen it, so.
Hi, Victoria, it's Leanne, one of the BH team.
Hi.
Hi, there, it was a schedule effective July 1, 2024. It's out there.
Okay. I haven't seen it. Is it on your website?
Yes, ma'am. I will put
Thank
a link to it in the chat.
That would
Thank
be
you so
great.
much.
Thank you.
Okay.
Absolutely.
Dr. Patel.
Hey, thanks so much. So quick question about the study itself. Is there any way we can have this study if we want to like make recommendations regarding study design, what might be considered scope creep? You know, there are people on the MCO side, surprisingly, that are pretty smart with, you know, study design. And so given that this is a partnership, we have things that we'd like to see as outcomes to help us better serve the members of Kentucky, because we're member-centric, member-focused. And so would love to see if that's an opportunity for us to be collaborative in this process.
Dr. Patel, I'm going to get a little miffed here. We are collaborative. Every bit of information that Victoria has provided to us is available on the website and to your MCOs, and we welcome their input. I've never sent out a request for information that said, I only want to hear from one group of people. So have at it.
Perfect.
Kathy.
Yeah, I have a couple of questions. I guess the biggest one is what's going to be done with this information? What's it going to be used for?
Well, I assume that it is information for us to use for whatever purpose.
Yeah, I just want to stress that the Children's Alliance would hope that phase 1 could be done just as soon as possible. You know, this is our top 30 most utilized codes. And, you know, we're hopeful that this information, as it is clear that Kentucky's rates, at least for these 30 codes, appear to be lower than the surrounding states that were used. And we would like to see phase 1 completed and move to another implementation of how do we get Kentucky's rates up and comparable to other states, you know. And I think that, or the Children's Alliance thinks that if we could at least go ahead and do that for phase one, the top 30 codes, that would make a pretty significant difference for a lot of providers, because these are your most used codes. So want to say that. And then one other question I had, well, I'm losing it. Just go on. That was, I guess that's, if I think of it, I'll raise my hand again. I apologize.
Okay. So anyone else have their hand raised? I can't see everybody. I don't see anybody else.
Dr. Schuster, sorry, I don't have my hand raised. I thought, and I brought this up on the prior call, you know, as the study shows that the other 10 states do not cover psychoeducation as a separately reimbursable service. It's a component, it's inherent. And DMS raised the rate in 23 by over 300%. And I thought if you lowered that rate, you could use that money, because we've absolutely seen providers exploit the heck out of psychoeducation. If you lowered that rate, those funds could be routed to the other services, actual, you know, clinical services, to incentivize the better clinical quality services. You know, use that money to raise the other rates. So I just want to throw that out there.
Sounds like a great idea, Stuart. So I just want to say, Victoria, that the rate comparison is not for the sake of rate. I mean, it is all about access to services. I mean, the reason that you hear from us about the rates is directly tied to access to services and network adequacy. So, I mean, there's no question there are other issues in terms of access, but at this point, we feel like it's the primary issue. Certainly, I don't know, 70% of the problem, pick your number. I mean, and I think that as you increase that, you can, because it's a recruiting and retention issue. The staff, we're losing staff to other states. We're losing staff to other out of this field altogether. I mean, just kind of giving you a background and context, and for your thinking moving forward, it is all about being able to recruit and retain the staff, because I've heard from many of our clients that they've lost licensed clinicians with 15 years experience to go work at the Kroger deli because they can, or go work at Amazon. We're losing people. And so the rate is a direct connection to the ability to pay staff at a adequate and competitive rate of wage. So that's why it's not that we are unaware or ignore the fact there are other issues in terms of access, but that one right now is just the most crucial.
Yeah, and the super high psychoeducation is incentivizing a ton of psychoeducation, rather than the other services. So, I mean, and there's a lot of money spent on that. So I think you could lower that, incentivize the other services, in this study, that would be a great idea.
Yeah, I guess my question is, and I don't know, Victoria, if you're the one to answer, and I don't know on what basis DMS decides to raise or lower rates. Yeah. I mean, what prompted them to raise the psychoeducation rate 300%?
Leslie, some of the BH team. You're the experts. Help me out here.
Here comes
Sorry.
Leslie.
So yeah, I don't think you want me to answer that, in that I didn't make the final decision. However, there was a justification that was brought forth, and we reviewed, and it was a cabinet decision to do that. So I think one of the things we were trying to do with what Victoria is doing, though, right, is to see if we were truly comparable to other states. And when she got into it, it's not apples to apples, which no Medicaid programs are, right? And so there was definitely a lot of variations when she was trying to go through that. So Victoria, just going back to what you said earlier, I think it would be very beneficial for you to show them why you didn't include some of those. It's not like we just chose not to, or the rate was, there was other reasons why. And so if legislation or General Assembly decides to fund something, like I think is what happened in one of the states, Victoria, that was something that was pushed forward for additional funds to increase those rates. So I'm just throwing that out there too.
Well, I guess the follow-up question, Leslie, for you is, does the cabinet go back annually and look at the rates and reevaluate them? In other words, you've gotten some feedback now, at least from the MCOs, that psychoed is rocketed in billing frequency.
And I don't want to misspeak to what Victoria's been working on for the commissioner, but I believe that Victoria, it is something we're going to try to take a look at annually, isn't it now? Is that something that you were going to try to do annually?
Yeah, I mean, we're keeping track of that now. Now that we've pulled that data and we're looking at that, we'll be keeping an eye on that. The other thing I would like to point out too is not all the top 30 codes were lower than the majority of the other states. So I do want to say that. I mean, I do want to give us
there were some
on that
nuances.
And we did give you a reason why we didn't compare them. I think you just need more information on that. So for those of you who have had an opportunity to look at the PowerPoint and then the accompanying workbook, we did add kind of all those reasons. I think we just need to help you understand like why they, instead of saying they didn't match, like why didn't they match? And then maybe you can help us understand that, no, that really does match. You know, like you were saying, Bart, no, that does match. You know, you're just looking at it wrong. I'm not the expert. You know, I'm just trying to look at the data, you know, read through the manuals, read through the fee schedules, read through the regulations from other states and try to match it up as much as I can. So we're not saying that, you know, we're the experts on this, and we're not saying that, but I do want to make sure we understand that all 30 of those codes were not lower. We weren't lower across the board on all the other states on all 30 codes. So, you know.
Yeah, I don't think any of us are saying that. I mean, people need to go back and look at the PowerPoint. And I guess that leads me to the question, because Dr. Patel apparently has never seen this, and I don't know whether Stuart has, but you had presented that at the last meeting. Where does that PowerPoint reside that you used last time?
I know
Dr. Schuster, all presentations shared or uploaded on the TAC. So this one would be on the Behavioral Health TAC website. I'm happy to share that with Stuart and Dr. Patel after the meeting.
Yeah, so people can always go to the DMS website, to the BH TAC, and look for those presentations. They're readily available. Thank you, Aaron, for the reminder.
I would say too, as far as looking at the rates every year, DMS did raise 20 of the 30 top services in 2024. We saw a rate increase on 20 of those top 30. So, you know, we are aware, and we do try to look at those regularly. So, I'm not trying to downplay the higher or lower or comparative issue on phase one. And I do understand that the direct correlation between how much we pay with how many people will do it and all that. I get that. I'm not trying to discount that at all. And I think that part of the study, though, is going to be easier done in the phase two part of it. If that makes sense.
All right. Well, Victoria, thank you for your expertise and your patience with us. I think this has been a good discussion, and certainly I have a much better feel now that we're looking at a refresh on phase one with many of those aspects. And then our phase two is going to be really focused on the barriers to answering those questions. And again, if somebody wants to put it in the chat, but my email is kyadvocacy@gmail.com, and you're welcome to share with me your thoughts about that.
So Dr. Schuster, if we can get those by the 30th of September.
30th of September, yes.
If we can get those by the 30th of September, that way we'll get you a project plan by the next TAC meeting, and then we will also do as much of that refresh from phase one as we can for the next TAC meeting.
That would be fantastic. Thank you very much.
And real quick, Dr. Schuster and Aaron, I do have the fees. Dr. Patel's not on these calls every time, and I have it. I apologize. I did not send it to him before, so I do have it for WellCare. Aaron, you don't need to send it to me, the presentation.
All right. Thank you.
Thank you, Stuart.
I did have one more question for Victoria. I hope she's not gone, and I apologize. I couldn't remember it earlier. But thanks, Victoria. And again, thanks to DMS for all your patience and hard work. We really, really do appreciate it. And you've done an outstanding job. And I may not be understanding, but I believe I heard you say that there were some, like a special circumstance where a state got extra money or they passed a bill and raised some of their rates.
Yes.
Did I hear it? So
and those are noted on the tables. It'll be noted. It'll say that this came off of this fee schedule and SB something, you know, and I would have to look at the table. I'm sorry, I don't have those states in my mind because there were a couple of them. And then there were a couple states as well that moved some of their behavioral health services to an ASO model. So those, you know, we couldn't compare because it was a different delivery model. But those notes are on the original workbook that we sent you. And if you have any other questions, Kathy, just send them through Dr. Schuster and I'd be happy to clarify.
So Kathy, is where the state probably had a bill and then it line item put money in the budget for that specific line item. So that it couldn't be moved anywhere else. It had to be for that one line item.
But those rates were included in the table, right? They were still compared, even though they got a rate increase from there.
Yes, but there was a note saying, you know, what we took it off of. Yeah.
Perfect. Thank you very, very much.
Yeah.
All right, let's turn our attention to my favorite topic, which is the 1915I SMI SPA. And I see that our friend Ann Holland is on. As some of you know, Ann Holland is leapt over from Medicaid to DBH and is heading up that. So where are we, Ann, with the 1915I?
I have to say it was kind of hard not to jump in there and talk about the stuff not, you know, freshly out of Medicaid and about the fee schedule and stuff, since that is what I used to do, right? The fee schedule. So, but I let Leslie and them handled it just fine. Good afternoon, everyone. As Dr. Schuster said, I'm Ann Holland. I'm now in the executive advisor within the Department for Behavioral Health, Developmental, and Intellectual Disabilities, and I am the lead on our side. It's kind of weird to say our side for the 1915I State Plan Home and Community-Based Services. I just want to level set a little that this state plan is for individuals 18 and older with primary SMI and or SUD diagnosis who need intensive support and treatment, but who are living either independently or with support in the community. They do not necessarily have to meet nursing facility level of care, but it is an eligibility process where we will assess them utilizing a locus assessment tool for SMI, a SAM assessment tool for SUD, and then a functional assessment tool called the Daily Livings of Activities 20, where it looks at their functional needs around activities of daily living. They also have to meet a duration and episodic criteria for which is hospitalization for a behavioral health condition more than once in the past 2 years, and either clinically significant symptoms of behavioral health that have persisted in the individual for a continuous period of at least 2 years, or a history of one or more episodes with marked disability and clinically significant symptoms are expected to continue for at least a 2-year period. I know that was a mouthful, but the services that will also be included in our state plan amendment are case management, and that means that person is going to manage all care, not just eye services. There could be traditional state plan services this person might need or already have. They will also have that listed on their plan of cares and ensure that they get all that they need. They will also have potential for supported employment, supported education. There's some dollars for transportation, assisted technology, plan respite for caregivers, medication management, in-home independent living supports, tenancy supports, and supervised residential care. With those last three, there is also the risk, must also meet a risk for homelessness. We are actually still in the negotiation process with CMS, so we don't have final approval of the SPA. However, we did submit on August 30th our responses to CMS to their request for additional information. So we're waiting now for a response from them. But part of the responses that we did amend or actually, use to improve our implementation, we aligned the capacity limits for supervised residential care to 3 individuals for maximum capacity in a home. It said up to 4, and that has tended to get some states in trouble because it classifies it as a group home. So we amended that. We clarified the target group by adding the state's definition of SMI and listing all SUD diagnoses as designated in the latest edition of DSM, with the exception of tobacco. We also changed the requirements for a case manager to align with the requirements that are listed in the C waiver case manager requirements. So it's a little more broad. And then, as I said before, the duration and episodic criteria, that also we ensured that read exactly the way I read it to you. So we're not just sitting and waiting. Next steps in the next weeks and months, we're beginning to work on our system updates, right, with DMS. So we're looking at system changes with the Medicaid, the waiver portal, the Medicaid waiver application. Oh, what did I say it wrong? Leslie, you might have to help me here. MWMA is what it's known as.
MWMA, correct.
Okay. Then as well as provider type development, the payment, the payment system, regulation development, and then decertification criteria for our providers. We're co-developing educational tools, communication strategies, and then community partner collaboration to design and implement of the services. So that's kind of where we're sitting right now. Any questions? I know I went fast.
And Kathy Dobbins had a question about, is this independent case management?
Yes, it is. It is independent. It's the same as it is like for C waivers.
Okay. So the case manager needs to be independent of the service provider.
Right. Correct.
The conflict of interest.
Yes.
Yeah.
Right.
Okay.
Figured that, but Karen.
Yeah. And as I said, we're working, the focus, I'll be honest, the focus was getting our responses back to CMS because we're looking at a July 1st, 2025 implementation date. So, we have to get that going. And then, so now we're starting to work on the other pieces.
And so you're in this kind of holding pattern with CMS to see if they have any further questions or anything.
Correct. But that's not going to stop us
from going on and working on the other pieces.
Yes.
Okay.
Yes.
All right. Anybody have any questions?
My email address is the same as it was when I was in DMS. So it's ann.hollen@ky.gov. I asked for that to stay the same since I was established with that already. And if you do, please do not hesitate to email me. I am pretty good about responding to my emails.
Yeah, we appreciate that. And thank you.
Thank you.
How about a status update on the reentry waiver? Is that you, Leslie?
Yes, I'm gonna go over that. And I just mentioned too on the 1959 state plan amendment, it's very similar. You all are used to working with our programs where we are the oversight for the CMS authority, and then we may contract out with Department of Behavioral Health or Department of Aging Independent Living. So we're partnering with this. So our role in that state plan amendment will be that we're still the CMS authority or oversight and compliance piece for CMS. So, and we've all been working really well together, and it's exciting. Remember, this is going to be a companion to our 1115 SMI for more of a holistic approach for Kentucky. Very, very exciting times. So as far as the reentry, there's some moving parts. I've made a lot of notes here to go over with you about. As you remember or may know, we got approved July the 2nd of this year for what they call the reentry opportunity, which is much different than what was submitted many years ago as an incarceration amendment for SUD only. So this one encompasses a larger population and then has a little bit of a narrower package of services. However, I do want to mention that we are really trying to work with CMS, and that's how we got approved on July the 2nd, was to stay in alignment with the state Medicaid director letter that came out in April of 2023, to get that approval quickly so that we have an approval to build upon. So we are very excited that we're moving forward. I do want to also mention, since there's a large amount of folks on here, I get a lot of questions about, okay, so you're approved, when do you implement? Well, there's a lot of things that go into an 1115. Unfortunately, there are a lot of things that we have to keep up with, that we have to implement, and that we have to have CMS approval before they will let us go forward on the first day. So we have an implementation plan due, as we did for the SUD back in 18 or 19, if any of you all remember that. The implementation plan will be due on October the 30th. We're currently working with our advisory committee right now. I think some of you all sit on the advisory committee, which is our Kentucky Advisory and Community Collaboration for Reentry Services Work Group. And I think we had a meeting last week that really started providing some preliminary gap analysis findings that we're bringing forth. We have a core team that some of you all may already sit on. We have bi-weekly meetings that discuss any key decision and decision points to make decisions on. We have a weekly work group with our Department of Corrections and our Department of Juvenile Justice. Just as a reminder, this is a Kentucky implementation. It is not just Medicaid. So we are working closely with our sister agencies that are even outside of our cabinets, the Department of Corrections and Juvenile Justice, and assisting them with project management, because this is very, very new to them. So we're working through those things. We just completed stakeholder engagement, or started earlier this month, to support the mapping of our current state and identifying needs and gaps. Those focus groups included providers, MAT providers, primary care providers, Department of Public Health, Department of Aging and Independent Living, Department of Community-Based Services, our MCOs, Department of Aging and Independent Living, I don't know if I said that one, and our Administrative Office of the Courts are also included. We are currently going around right now and meeting with a lot of the court systems. We've already done training with the mental health courts, circuit clerks, and then we will be doing the Judges College. I think that's Monday. We will be doing the Judges College. So just wanted to mention that, and trying to share with them the vision for the state and what these opportunities are and what they're going to look like currently going forward. A couple other reminders that I've been getting questions about. We asked for 60 days because we were trying to stay in line with the state Medicaid director letter to get that early approval with 3 other states. So we were allowed with 3 other states in a cohort to get approved out of that long group that were waiting. But we can also ask later for additional expansions, but we want to get something quickly to build upon. So we did ask for 60 days prior to release, and that's what's available to us right now. We're still kind of currently looking at that gap analysis I told you about and doing a needs assessment. The implementation plan that I talked to you about that'll go in first to CMS will be high level, because it will be due at a time that we're really still working on a lot of things that we have going on here in Kentucky and partnering with our sister agencies. After the implementation plan, we have to develop monitoring protocols. Those are due in November. And then we also have to develop an evaluation design that shows CMS how we will evaluate ourselves. We have an independent assessor that will handle that, part of that, and then we have to report to CMS constantly. There is one other piece to this reentry that we've never had before, and it's called a reinvestment plan, and that is due in December. So if you can hear all the things I'm telling you that are due in the next 180 days, it's very daunting to think about what we've got to get done, but believe it or not, we are on target. So just keep your fingers crossed and continue to work with us. The reinvestment plan will be only those services that currently are being covered. We can reinvest those dollars back into the system. So they can't be used for anything else. They have to go back into the reentry system. So as those kind of services maybe later get expanded, those would be more reinvestment dollars that we could have. Right now, we only anticipate the 30-day supply of medication at the time of release to be a piece of what we would be able to reinvest, and DOJ's or DOC's covering that right now. So again, very exciting times, lots of work to do. And the partnership has been wonderful. I don't know if you all were aware, but we are part of the Nashby and Harp collaboration. And I was so very proud, if you saw on our social media, with the Office of Drug Control Policy, the Commissioner Van Ingram, the Commissioner for Department of Behavioral Health. Angela and I attended for Medicaid, and we had the Commissioner for the Department of Juvenile Justice all together, standing hand in hand in Washington, D.C. together, working with other states and collaborating with them and trying to help with best practices as well to help these states that are coming in after the four of us, if that makes sense. So all very exciting times.
Thank you, Leslie.
Yes, ma'am.
I think I would ask what services does an individual with an SMI get? What are they eligible for in this reentry waiver?
So currently right now, and I wanted to go over that with you today, they are only eligible for the services that CMS says that they can have that 60 days prior to release. So that's intensive case management, Medicaid assisted treatment if there's an SUD diagnosis, and 30-day supply of medication, and that includes physical health and behavioral health medications. Once they leave, let me back up. During that 60 days, they will be connected with the MCO of their choice. And once they leave, there's things like education, food, housing, all those things that we would expect in social determinants of health to help to be identified before they leave and be aligned for them upon entering back into the community. So we want them to be successful. We want to help them to have everything, the tools that they need when they leave the setting, either incarceration or confinement for DJJ youth, and to have a 1-year follow-up with the MCOs after incarceration. So we'll follow up with that intensive care management for 1 year after they leave the incarceration.
So are we assuming that they're getting some mental health services in the prison or in DJJ? And these,
yes,
so these would be adjunct to that?
So, yes, ma'am. And we are not allowed, CMS has made this very clear, we are not allowed to supplant any dollars that DOC or DJJ, Justice Cabinet are currently covering. All individuals have the right or access to health and mental health services, physical health and behavioral health services. So I don't know if you remember, Dr. Schuster, but we met back in 2020 with the services that are out there, and that they were growing at the time with Sarah Johnson, which I believe just moved over to the Department of Behavioral Health. We're so glad to have her in our cabinet because we worked with her a lot back in the day. So they have SAP and SOAR. You remember we talked about that with the substance abuse recovery system, and then SOAR was substance use system, and then they also have a recovery system, the SOAR program. So it's been a while since I've looked at that. They don't have that in all facilities, but that is growing, but they should have access to what the holistic need of the individual. So anyway, it's still a lot to come, still a lot to learn. And can we expand later? Sure we can, as long as CMS will approve it.
Okay, any questions or anything you want to add, Steve? Because you're
I mean, there's a reentry TAC. It's really a good place to get much more great information by Leslie. That was about 45 to 50 minutes of the reentry TAC meeting this morning, outlining what it is. And again, I think it's important to remember it's individuals leaving state prisons, not state prisoners, because there's a lot of state prisoners in jails. We're not there yet, right, Leslie? And it's kids at youth development centers and DJJ, right? That's the target right now. And it's really anyone leaving. We learned today there's about 8,000 people a year discharged from a DOC facility, Department of Correctional Facilities. Wow. That's 8,000 people, and they're going to get 14 months of case management, right, Leslie? 2 months prior, 12 months afterwards. MAT if it's an SUD diagnosis, right? And those other services, connections, housing, vocational stuff, those aren't waiver services, but the connection is the waiver service, right, Leslie? So.
Yes. And then we have already started our collaboration with the jail associations already. We do want to look at those in the future, but an 1115 is one of those things when you tell CMS you're ready to implement, it can't be that these 10 jails are ready and these 12 aren't, and these.
It has to be available to
somewhere.
everybody,
It
right?
has to be eligible to everybody across the state. So that's where we are, Dr. Schuster.
Yeah.
Yeah,
And
and
the
they
state
each
prisoners,
run very independently. as
They
I
do,
understand.
very,
Yeah.
very individualized, they're elected officials in each county. Yeah, and DOC will also tell you that, there's a lot of differences in each county. So we're working on that and figuring out how we can align that later, but there was no way we could meet the deadlines with
Right.
I think there's 52 or something like that jails across.
there's a lot.
Nina, do you have a question?
Yes, real quickly. I had an opportunity to participate in one of those focus groups and it was wonderful. It was really great. The only concern I have, and we don't have to talk about it, I just want to put it on the table, is that my understanding is that to participate in the waiver services, you have to be linked to KHI. And that if you don't have an EMR, you may not be linked to KHI. And so I don't know if that was accurate, what I took away from it, but if if you don't want to respond now, but if we can at least keep that on the list of things to clarify.
I would just mention two things, Nina. Thank you for bringing it up because I didn't mention something else. So this opportunity also, because many states, the Medicaid department is not connected with the Department of Justice or the Department of Correction or DJJ. They've allotted us some additional IT funds for technology because we don't have the linkages, especially even outside of our cabinet. Even if they were in our cabinet, we might have limited access. So that's one thing that we're looking at. If you heard KHI brought up, I don't think that was a final decision. We are trying to find a platform that we have to leverage and or to figure out if we need to build one and how we can incorporate what DOC and DJJ have some current similar technology-based systems, and we're trying to figure out how we can leverage what we have with that to develop it. We also, not that you all want to hear all this, we also have the ability to apply for, if we decide to, additional funds for technology at what they call a 9010 advanced planning document. So that's that. None of that has been decided yet, though.
Yeah.
But thank you.
Thank you very much.
The reentry thing specifically said health data exchange, did not say KHI.
Oh, okay. We
But
have said it, but it's not
right,
like
but the language used was health data exchange. They still need to have that mechanism, but it wasn't specifically identified yet.
Okay, does that answer your question, Nina?
It does, but I'll tell you, in my group, KHI was mentioned. So the clarification that Leslie's provided is really, I'm very optimistic about that. Thank you very much.
Yeah, all right, thank you. Our next item is, can providers respond to an ultimatum from an MCO, or how can they respond? And the ultimatum is take this 10% cut in rates or we'll end the contract. So I guess I'm looking for some guidance from DMS about, as we've asked before, about audits. What recourse does a provider have in that situation?
Hi, Dr. Schuster. It's Veronica Cecil.
Hi, Veronica.
No. I think what our response to that would be is that it's a negotiated contract. It takes both parties to be mutually in agreement, and the provider does not have to accept it. That's just unfortunately the reality of the situation. So I will tell you, because this is starting to come up a lot. So we are holding the managed care organizations in compliance with our contract that ensures access to services, so that they have to have an adequate network. When they do have a provider that might terminate from their network, that they have to follow and provide us certain information to make sure that there is a smooth transition of care. And so as these are starting to pop up, I can assure you that we are requiring the MCOs to meet our expectations on access, network, and transition.
So how do you know that the letter's been sent? Let me ask a real basic question. In other words, I guess I'm asking, does the provider need to contact DMS to tell them that they've received such a letter?
The managed care organizations are required to notify us when they are making a rate change, that especially if it's going to cause abrasion, but if that it will result in a termination of a network provider. We've heard it from both sides, though. I mean, we've had providers that have reached out to us, obviously concerned about receiving reductions from multiple MCOs. So, I mean, providers are welcome to reach out to us when they're in these situations. But as I said, you know, we have to kind of step back. We're not a party to that contract. And we have to monitor it from our side, which is really about access and transition of care for the member.
Okay. If a provider felt the need to contact you all, what part of DMS should they contact, Veronica?
That would be the managed care monitoring compliance branch, and we can put that email address in the chat.
Yeah, that would be helpful. Any other questions from anybody on the Zoom? Want to follow up on that at all?
You know, just kind of one other fine point to that, Dr. Schuster, is MCOs need providers. They need to have adequate networks. And I think the other thing that, you know, we're encouraging MCOs to do is to make sure they're having a conversation with providers. You know, they have to follow a process. So they send out something notifying the provider they want to reduce the rate. They have to give them a certain amount of time to respond. And then if they decide, if they can't come to a mutual agreement, you know, the contract speaks to how they can, you know, end the contract. And so all those things have to be followed. But, you know, the other thing we're just trying to recommend for providers is to try to have that conversation. You know, what is it maybe differently that you could do to work out? Maybe quality metrics. I know that's what we're hearing a lot from managed care organizations, is ensuring that it's not just about having the delivery of services, but quality services. And are we looking at outcomes? And so we always encourage providers to try to, you know, have those conversations with managed care organizations about what you can bring to the table and why you should get paid more. I know several providers that have done that and have gotten, you know, at least 100% of the fee schedule, or maybe even more, if they can deliver better outcomes as a result of the delivery of the services. So I just really encourage, you know, we're encouraging the MCOs to come to the table with providers to make sure that they're having those conversations, and again, ensuring that access.
Yeah, I think we are very concerned about access, because I think in some ways the headcount for providers treats the different behavioral health professions as if they all do the same thing and have the same training and see the same people and provide exactly the same services, which is absolutely not true, for one thing. So one does not equal one does not equal one. And it's scary when some of the larger MCOs that have so many covered lives kind of throw down this gauntlet, which is what it feels like to the provider. And I think we've had that discussion on previous TAC meetings when this has come up. I think also we need to remember, and I had this conversation with a legislator very recently, that in a lot of cases, the behavioral health provider is really a cottage industry. I mean, once you get outside the CMHCs or the BHSOs, there are just a ton of
small little folks
of single practices, or maybe two people in a practice, and they have a very part-time staff person or that kind of thing to answer the phone occasionally. And so these cuts in rates, you know, are pretty darn scary. If we keep focusing on access to services, then we obviously need to keep our behavioral health providers out there. So Thank you.
You're welcome.
Who has maybe the current 1915C waiting list numbers?
Sorry, took a second to get off.
That's all right.
Just a second. I think I have everything you asked for. So let's see. I think this was as of yesterday. I've told you all, I can check on these every 20 minutes and they change. So just, if you're in a meeting in the morning, in the afternoon, and you see, they're fluid, so they just are. ABI, is 0, ABI LTC 0, home and community based is 2207, model waiver 2 is 0, Michelle P waiver is 9169. And SCL is 3536. That's the waiting list counts.
Well, that sounds really high for Michelle P. I can't remember the last time I got the numbers from you, but I would not have remembered that it was in the 9,000s.
Now, Sheila, this was the last time I think I talked on maybe the Thrive meeting. I had 9227. I know it's
yeah.
a lot now.
Okay, I'd have to go back to our July BH TAC. Anyway.
Like I said, they're fluid.
Yeah.
And then your other question was regarding, I think, how long does it take from the time they get a slot allocated to receiving services? So we did this in a couple of waves for you. I've got the average by days per waiver, and then I've got an average for all the waivers, and then I did a 3-year period trying to catch comparable time periods. So I don't know what exactly you want. I'll go ahead and give them to you. Average days by waiver. So ABI is 73.8. HCB is 59.14 days. Michelle P waiver is 94.41 days.
94.41.
I'm sorry,
94.41.
And SC, I could have rounded these off, wasn't thinking. And SCL was 63.8.
So that's from the time that they get notified that they are off the waiting list and into a waiver. And what are you counting as the beginning of services?
I think we did from capacity. They've went into capacity to get a slot to the time that they are PA'd to start services. I think that's how they pulled it for me.
So approved to get services.
Yeah, let's see. So if you average, if you averaged all those waivers together, I wanted to show you this because this actually made me feel a little bit better. So I'm going to share it with you.
Okay.
Using the reserved capacity, the day that they've been told that they can go forth, right, to the day that they get the PA, all waivers together from September the 1st of 21 to August the 31st of 2022, it was 106 days, 0.41. So 106.41. And then I did the next year from 22 to 23, and that was 120.28. So that went up. And then from September of 2023 to August the 31st of this year, we went down to 66.57. So that makes me feel a little bit better.
Yeah, that's almost cutting it in half.
Yeah.
So what?
Sheila, can Leslie put that in the chat so everyone will have access to those numbers?
Yes, and I tried to capture those too, Mary, but that would be great.
I've got it on a large let me just send it to Erin and she can send it out. Is that okay?
Yeah, that's
it's
fine.
fairly big. I've got a grid. Okay.
Yeah, that would be great. So I just talked to a mom today who has been waiting on PDS services in Michelle P, and it's been like 2 years.
I don't know about 2 years, but I know that there are folks that have been waiting for services. We are addressing it. We've got some questions from CMS. I think you had asked at one point, maybe on another call. We don't have an official cap or anything like that, but we are working with CMS and a contractor to help us make some decisions, how to improve that process here at Kentucky for our members. And I think we have a meeting with CMS, I want to say the 30th of this month.
Okay. Yeah,
Kind of
Michelle, the wait list in the July meeting was 9,200. Just shows my memory is faulty. Thank you.
Yeah, it was 9214 and the SCL was 3553. So when we heard those numbers today, I thought, woo-hoo, they both went down some.
Yeah. So you're going to be talking to CMS, Leslie, about the PDS?
Yes, we had an additional meeting with CMS just to discuss PDS. So I can let you all, I don't have an official cap or anything like that, but they have had several informal conversations with us about you know, how to streamline the process, how to figure out other ways. They want us to come up with recommendations too about how to streamline and make this process quicker, because we don't want anybody on any waiting list at all, right? So I wanted to tell you all too that you all are aware that we released the 2025 slots. So that also, when we were in that process for that first couple of weeks, I noticed that there was quite a bit of an increase of applications coming in. Even though there were waiting lists, we had an increase in applications. So it was like the waiting list was growing while we were like trying to get out. Yeah. So, and then we don't want those slots that we've released to bottleneck. So we're kind of releasing those slowly. We've got a 3-month plan to get all those out there, because I know this is hard for folks to understand, but we are never at like 100% full capacity, because there's always this overflowing amount of slots that folks don't utilize or allocations. Once we get those allocations out there, that they either don't meet eligibility, or they're on another waiver and receiving services, they've moved out of state, they've passed away. There's always this regular rotation we do every month. So I'll get asked, like, you know, why did you release 50 slots last month or whatever? And it's because of that rotation. It wasn't an additional 50 we received. It's already in the 50 that we already had, if that makes sense.
Yeah. Let me ask you one follow-up question on the PDS. Have you all authorized more agencies to provide case management for PDS?
So those are things that we're looking at, Dr. Schuster, and I don't want to speak to that today. We're looking at several options that that we're going to take back to CMS and talk to them about it. So I don't want to say anything today that might end up not being. That's not too far away though, because like I said, we've got conversations with them. We have not received a formal cap, but we do know that they have concerns on the PDS process.
And there's two pieces to PDS, right? Let's say there's the financial management piece and the case management piece.
That's correct.
Yeah. I just am hearing up from a lot of folks about PDS and about being in a waiver and not getting those services because they want PDS services. So I'll follow up with you, Leslie. I appreciate it.
No problem.
Yeah. All right. And then the questions, update on the ABI waiver, access to therapy services. We understood that there was still a holding pattern.
Okay, Sheila, can you hear me? Can you hear me?
Yes.
Okay. Update on ABI. Everybody's still in the holding pattern. Leslie's still on here. Maybe she can tell us something. The one scary thing is I was at a provider meeting, and they're saying that after the therapies come out, they're going to take behavioral services and counseling services also. I don't know if that's a rumor or if Leslie can address that, but that's the thing right now. We are just not in a good position with providing services to our ABI waiver constituents. Right now, Neuro Restorative just bought out an ABI long-term care waiver provider in Louisville, which is very concerning. So pretty much unless you choose Neuro or one or two small mom and pops, you really don't have much choice. And I'll just speak to the Louisville area because that's what I know about this. This just came about supposedly effective October 12th. Neuro Restorative will acquire the one larger ABI provider here in Louisville. Then you have the other issue, which you just talked to Leslie about, PDS services. Because of the low availability of choice of ABI providers, many families would like to do PDS. Their loved ones are already in the waiver, but you're looking at a long, we're talking 4, possibly 6 months for somebody to be able to access the PDS services that would be able to get them a provider to help them as far as providing companion care, other needed services that they're currently getting in the waiver. So it's a big issue because many families feel that if they could go the PDS route, their loved ones would be better served. But right now, I'm very depressed. ABI looks nothing like what it did even 2 years ago. With the long term and then acute, what I'm hearing families, again, these are from families, are saying they're having a tough time, that evidently they're being told they have to automatically go into long-term care, which right now there's not a waiting list. But again, some of these folks could benefit from acute services. And I don't know if Leslie can address why some folks are being turned away.
I'll go back just a little bit. So, no updates, or we've not moved forward with the ABI therapies. We do have a consultant that's assisting us, and I think we've been trying to do a little bit of research in Kentucky about our therapies as well. So nothing has moved forward. Promise you we'll do tons of communication. Mary, I wouldn't just say it's tomorrow. I would not do that. So I'm working in brain injury for 20 some years. I know that we've got to have lots of communication and lots of working, and I wanted to have working with the members, and I want to make sure that we have options if we move forward. Like I'm talking about options like step-by-step processes, what that looks like. For you all to have it. I wanted to have FAQs, all those kinds of things that we worked on years ago when the state was looking at this as well. One of the things, I think it's probably, Mary, just the fear of the unknown about talking about behavioral health services and other things like that. The ABI acute waiver, because I was there from the year one. We were the first waiver in the state of Kentucky that offered a lot of the psychiatric services that were not in the state plan at the time, right? We had family group counseling, we had counseling services and things like that. We even could allow substance abuse counseling, where none of the other waivers had that. And we were allowed to do that because the population that we were working with, it was mental health in nature. And we were able to get CMS to agree to that. Number one, because it wasn't in the state plan. So I'm sure those conversations are starting to come about because of the fear of the unknown, because they are in the state plan and have been since 2014. So I apologize.
The problem I see as it is now is that no one really realizes the difference between ABI and even though mental health or your intellectual disabilities. I was told the other day when I said something, they said the SEL folks aren't complaining. Again, that's why you have two different waivers. You have an SEL waiver and you have an ABI waiver. And I think right now everybody's trying to group everybody together, and it's just not providing a good service to our folks. And like I say, right now we have 2 or 3 people, and I think Sheila's aware of one of the folks that I'm talking about, that I can't understand if you have an ABI waiver slot, why you cannot automatically just go over to PDS. I mean, I understand part of it's the case management, and it's kind of what Steve said. You also have the fiscal management, and a lot of the current ABI waiver case managers will do what you call more traditional case management in the waiver, but they don't want to do that fiscal management piece. And so those are some of the things, and we just really need to have a good conversation around this, because ultimately the folks I care about, and folks like you said, back to the days of Colleen Royale, we're just not providing what they need. And again, part of it is again, when you have one provider having, again, I don't know, you'd have to tell me the numbers, but if they acquire the other section in Louisville, they're probably going to have 50% of the ABI population. And that's just scary to me, that you have one provider having that much control. And if I get taped, I get taped, but it's just very scary to me.
No, I appreciate you sharing that with us, Mary. And
This is-
again, at least you've got me working where I've been in brain injury for many, many years. So, again, haven't moved forward on anything related to the therapies and won't until we make sure that we communicate with the public wholeheartedly.
Okay. Okay. Well, I appreciate that. Thank you.
Yes, ma'am.
And then, and nothing else, Sheila, I do have to jump off, because I have another appointment at 4:30.
All right, thank you. Misty, do you?
Yes,
you-
I have a couple of questions as it
Yeah.
relates to provision of therapy services under the state plan. So one of my concerns and just general areas of interest is the authorization process for therapy services is often very cumbersome and lengthy for providers. And from what I've seen in my own experience is that often they're requesting that outcome measures be used, which I am not opposed to, provided that those outcome measures are reflective of the neuro population and they are sensitive to change, especially for individuals who are in a chronic state where they are not going to show significant improvement on some of these measures that are utilized. So I'm just curious if you could speak more to that and if there's any consideration to the types of measures that are being requested when we're requesting authorization. And then moreover, I'm also interested if whether or not the state has considered there being a baseline number of visits approved for patients with brain injury.
Mm-hmm. So if you're using state plan services, then the state plan services have already been designated, the units and numbers, and I don't have all that in front of me, and it's been a while since I've looked at it, but I wanted to say too that part of the communication I was talking about earlier was how you go about utilizing and accessing those state plan services for folks that aren't used to it. So I would get with like our director, Justin Derringer's area, who also handles therapies, and we would get together and develop, which we did this back when CMS was asking us to remove these back in 2014. I can't even remember what the year was now. But we developed a lot of back and forth, like conversations, FAQs, processes, one-pagers to help folks, whether you'd be a case manager or a provider in general, or if you were a member, guardian, representative kind of thing. So we developed a bunch of one-pagers back then too. But those are the things that we've got to address, and that we're working with a contractor to get all that in place for you. So again, we're not moving forward at this time. This is not a new conversation. I don't know if Mary Haas is on, but
Mary had to get off, I
we
think.
went through all of this back in somewhere around 2012 to 2014. I can't remember exactly the timeline. So I just want you to know it's the same conversations from CMS saying, why haven't you done this? Why aren't you doing this? Why can't you do this? And so my involvement back in 2014 was pretty stern with the federal government, and they didn't want to hear that OT or PT was different with brain injury than any other population. And at the time, I was very involved with brain injury and went to bat for it. I had several of the doctors in our arena in our brain injury arena to write letters to CMS to help us to argue our point. So they weren't willing to listen. So that's where we are. There's about 3 options in the CMS technical guidance that's about 300 pages long. There's like 3 options. And so we've got one of the 3 options. You either have it in the state plan or you don't have it in the state plan. And remember last time we looked in 2014 or so, 30-some thousand people were utilizing it. So we wouldn't want to remove it from state plan services. You can have it in both, but there are extreme limits when you do that, and oversight and watch. Or you can utilize the state plan and then the waiver as well. And then you have to ensure that you use the state plan services first. So we've been through this over the years many times. So I just wanted to let you all know that at least we're versed in it. But if you're a person who's been around in brain injury for a long time, it's the same conversations that we had many years ago. It's just come back up to the top from CMS.
Did you have any other questions, Missy?
No, I just hope that there is some consideration to the types of items that are going to be utilized for those authorizations. And that perhaps there's engagement from the providers to identify appropriate items for that. That's my only comment.
Thank you. I think we may need to have some additional, these same questions about the ABI waiver and these services has come up probably for the last year or more on the BH TAC, and we probably need to. And with you on the BH TAC now, Misty, let's you and Mary and I talk a little bit about what we might do going forward. I think that I'm going to skip to Veronica. We have unwinding on here as always. I don't know if you were prepared with something or not. And you're muted.
Yeah, I could do a really quick one slide to update numbers if you.
Yeah, let's do that.
Okay.
Yeah.
All right. And of course, we'll share this with the group and post it afterwards as well. Let me get my screen. Sorry, I should have had it ready. Ready? Okay. I'm gonna limit it to the past 3 months, and this is sort of, you know, from when we last spoke,
Right.
to give you updated numbers. So most recently is August with 36,136 individuals that went through renewal. And we had a really nice large approval number for August. It's a smaller number overall, but still, we're always happy to see a really high approval rate. So we had 31,823 that were approved, 979 terminated, and we have 2 pending from August. And we did extend 3,332. Just a reminder, extension means that we are still under the flexibility where we can extend somebody. All members 1 month, and long-term care 1915C waiver members up to 3 months if they've not responded to a notice, a renewal notice, and have to take an active renewal. So we conduct additional outreach during that period of time. So we did extend 3,300. We already have 50 that have been reinstated in August from the August renewal. And we're tracking that 90 days because, as a reminder, if anybody can come back within that 90 days following their renewal month after being terminated and provide us the information, and we can determine them eligible, we can automatically reinstate them without them having to ask. And it's as if there's no gap in their coverage. So looking back, you know, still tracking June and July's 90-day periods. The numbers are a little lower, but the renewal numbers, overall renewal numbers, are lower as well. So that's why, you know, I think we're seeing smaller numbers. So that was really all I thought I'd share for today, since we're running out of some time.
We've done run out of time, I think. That's a really low termination rate. I love seeing that.
Yes.
Thank you very much for that.
We do too. And I know the other question that we get asked a lot is what's up with the child renewals.
Right,
And
right.
we keep hearing from CMS that they're going to reach out to us, that request is still pending until we hear otherwise, though, that we have been extending children automatically. So we'll let folks know if we get any kind of response back from CMS.
Okay. I think I put the children specifically on the MAC agenda, so that'll be in 3 weeks. So we'll get that update. Thank you.
You're welcome.
Of course, we all are very dedicated to keeping kids on there. Any new recommendations to the MAC at the September meeting?
Yes, this is Nina. two things, and I'll be quick. IOP and PHP were recently acknowledged by Commissioner Lee to be able to be provided by telehealth. And that was after she really worked hard with CMS and others to give us that feedback. And so the previous communication that from the cabinet, from DMS, that precluded that was overridden by her direction. We just have one problem, and that is that the providers at all levels, the hospitals and outpatient providers, need some kind of provider guidance from DMS, and also specifically some communication about billing. The telehealth billing, previously it was under the public health emergency, and we don't know if it might be different. So PHP, IOP. And I think that's coming through the hospital TAC as well. And then my second thing is EPSDT services, specialty select services that are currently provided in a variety of hospitals in the state. Commissioner Lee and Secretary Freelander worked with many of us and did approve an increase to $700 per day. And these are very intensive hospital-based select services, like for sexually aggressive boys and girls and so on. Anyway, that was all great, but all the MCOs are refusing to implement those rates. Even WellCare did implement it in one hospital, and that was because they had a contract that was specifically written around that for their EPSDT services. Of most concern is that Aetna has refused to implement it at any of the provider service, at any of the hospitals. And Aetna, of course, has the Sky contract. And in any EPSDT inpatient program, the vast majority of patients are Sky kids. And so that's the other one. Thank you.
So are you raising those as questions for discussion here? Are you suggesting that we make a recommendation?
Well, I don't think we have time for discussion. I don't know if the DMS has a simple answer to those. But they're really just two things. IOP, PHP, we appreciate the cabinet's approval for telehealth to be re-implemented, and we need provider guidance on anything that we need to do specifically to re-implement that, because I'll tell you, nobody's doing it yet. Because we don't know exactly how to do it or how to bill for it. And then the EPSDT.
Hey, hold on that.
Yeah.
So I guess I'm going to ask if are there any voting members of the TAC that want to make the motion to make that recommendation at the MAC meeting, that DMS give guidance to providers for delivering and billing for IOP and PHP services via telehealth?
Motion.
TJ, all right. And a second?
Second.
I'm sorry, Val?
Yeah.
Okay. All right. All those in favor of making that recommendation, again, this is just voting members, signify by saying aye.
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 Aye. We need one more vote. Is Steve on? We lost a couple of our voting members is our problem.
Yeah.
It looks like Tara, I think, is still on. I'm not seeing Steve. I'm not sure you have a quorum currently, Dr. Schuster.
Okay. Well, I'm sorry.
Okay. Okay, never mind. And we don't have a quorum on EPSDT, although I did just get an email within the last hour that I do have a follow-up meeting scheduled with the commissioner on my EPSDT concerns. So we'll hold, in light of those two issues, we'll hold on that.
And Nina, we can take those back after this meeting and go ahead and start working on those.
Thanks, Erin.
Yeah, I was going to say, let's put it in the minutes, and we will also put it on the November agenda, Nina, if they're not resolved by then.
Thank you very much.
We'll make that recommendation. All right.
Thank you. Yes, ma'am.
And I think if Barry Martin is still on, he had an issue that he wanted to bring up under new business. I don't know if he was able to stay on.
Dr. Schuster, for the record, Steve has joined us again, so you do now have a quorum.
Okay.
Just for the record. So we can take that back, or if you want to, we're happy to take that back and work on it prior to the next meeting and do a recommendation then, or you can redo your recommendations. Totally up to you.
Let's do that. I mean, we put it on your radar, the radar of DMS. Let's see how much progress we can make, Nina, between now and November. Because all the making the recommendation to the MAC is just simply going to put it on DMS's radar. Okay, thank you, Aaron. Is Barry Martin still on?
I am, Sheila.
Oh, okay. Go, Barry.
Okay, just something for new business, just to consider. We've got some issues with IOP, intensive outpatient therapy, and that, if a patient does not get that third visit in the same week, that the whole service is disallowed. And we just wanted to see if there's any room for any kind of movement to change that methodology, or, it seems like it's not fair that if we provide 2/3 of the service, and if somebody has a doctor's appointment or gets a court, is ordered back to court, or if something happens that third visit in that week, there is no way to get any kind of remuneration for it.
Sheila, I'm sorry.
Oh, that's right.
I was just going to make sure that you know that it's 3 visits in a rolling 7-day week, not in a calendar week. This has been a huge issue for hospital providers, and that's one clarification we received. The other thing we've been trying to figure out, and I think we're still working with DMS on this, is whether or not for those visits that are not provided within that time frame, and I think that's a CMS interpretation. DMS, correct me if I'm wrong, but that isn't able to be changed. But whether or not it would be possible to component bill any of the services provided within the IOP if that 3 visit and rolling 7 days isn't met.
Right.
But I will agree with you, from all the providers I've worked with, it's a huge issue.
It is. So I was asked on behalf of some of the SUD and behavioral health providers to bring that up, and for us as well as Beacons of Hope, is just let's start a conversation of how we can remedy it. Maybe we understand the intent.
So IOP is a very important service, for sure.
Yes.
To provide intensive services, short of having somebody have to be in the hospital. So it allows them to still be in the community and have a job and do all those kinds of things. So you're saying, Nina, that the 7 days is not a Sunday through Saturday.
Correct. It's a rolling 7 days.
A rolling 7 days.
It's a rolling 7 days, and that interpretation has been provided and clarified by DMS. I'm not optimistic that anybody's going to be able to change the 3 visit rule within the rolling 7 days. We've been working on this for about a year. And so I think that the only thing, and all of us know that sometimes people don't show up for visits, or they, that doesn't indicate that they're not in continued need. And so I think the only other outstanding question that I've come up with, and others, is whether or not for those services for which we cannot bill and or that are being recouped, because that's another issue that's happening for providers, is the recoupment.
Right.
Can we bill for a component? Can we take that apart and identify billing codes that are DMS authorized, provided within that IOP, encounter, that we could bill for separately? And that's one thing that at least the hospital TAC and the hospital community is continuing to try to clarify. And I think the answer is the same, whether it's a Children's Alliance provider or a hospital provider
Right.
that's doing the IOP. So I do think that's important to keep out there.
Right. Well, and from an outpatient standpoint, in a clinic setting, having IOP available 7 days out of a week is kind of hard to keep providing on the Saturday and Sunday.
Yeah, hospital providers don't do it either. It's a Monday through Friday service, but at least the rolling 7 days, if somebody starts on a Wednesday, they couldn't possibly get in 3 visits if it ended on Friday because it's usually provided 3 times per week. But the rolling 7 days did help. And I don't want to, I'm sitting here talking like I work for DMS. So if I said anything wrong from some of the DMS interpretations, please correct me, but those are my understandings.
Well, and this might be one of those things where it would be helpful to have you on this, Nina, because you're also with the hospital TAC, where 2 TACs are working on the same issue.
Right.
And there is some synergy there that could be really helpful.
Right.
Barry, I will put this along with Nina's issues on the agenda for November, and let's see in the meantime if we can get some response from DMS on those issues. Okay.
Okay. I appreciate it. Thank you.
Yeah.
Thank you, Nina.
Barry, Nina, this is Erin. Would one of you mind to put that in writing for me? I try to catch as much as I could taking notes, but I want to make sure I capture all of the issues and the billing, and I can get that over to policy to start looking at.
Sure. And what
Thank
I'll
you.
send you the communications from Commissioner Lee and from DMS that have advised as to how IOP is to be administered and what the limits and rules are.
Thank you.
Yeah.
Yeah.
Thanks.
Yeah, Barry, why don't you send in your specific question, and then Nina, you'll do your IOP, PHP, telehealth, and then the EPSDT.
Okay. I
Yeah.
was going to say Nina sounds a lot more elegant than I do. It's more educated.
Well, the 2 of you could work that out about.
Yeah. Thanks.
So,
Thank you.
one final question there, because we always ask that. Are there any formulary issues, any access to medication issues out there that anybody knows of? Because we always ask that, because we're always happy to have Dr. Ali join us if there are any. We know how important medications are to our folks. Hearing none, I appreciate so many of you staying on until we actually adjourn the meeting here, 35 minutes, but we had some very robust discussion. So the MAC meeting is September 26th, and that's 9:30 to 12:30. And then our next BH TAC meeting is November the 14th. So thank you all. And thank you, Erin, for keeping us on track and so forth. And with that, we will adjourn the meeting and wish you all a happy rest of your day.
Thank you, you too, Dr. Schuster.
All right. Thank you. Bye-bye.
Thank you, everybody.